All right. This is the Man Up Podcast, the doctor's guide to men's health. Each week on our podcast, we interview the top specialists of the field on various topics in men's health. You have questions that you are too afraid to ask, we have the answers. This week, our episode is titled Get Hard, Treating Erectile Dysfunction. I'm Dr. Kevin Chu, and I'm joined as always with my co-host, Dr. Justin Dubin. What's up, Justin?
Kevin, good to see you again. I saw you less than a week ago.
It was great.
Person.
Yeah.
I don't know when we released this, but it was good to see you in person as always.
Yeah.
And now back in cold Chicago, so that's always a wonderful thing. But
some things just don't change, you know. Giants
no,
lost,
but,
you know. Steelers won. Yeah. Well, man, it's just
that's rare this year. But
oh, okay.
But yeah, so back in the clinic, back in the swing of things. And I think today's topic is really important because I think this is something that most men either are already dealing with or will deal with at some point in their life. And this is one of the main topics that all doctors, especially us urologists, and topics that men want to talk about or are interested in talk about or maybe ashamed to talk about. So we're going to be talking about erectile dysfunction, really focusing on the treatment. And we're really honored to have Dr. Mohit Khera joining us. He's a professor of andrology at Baylor College of Medicine. Hi, Dr. Khera. How are you?
How you doing? Thank you, Kevin, Justin, for having me on the show.
Oh, we're very
Awesome.
honored to have you on here. And I think the listeners are going to get a lot of great information from you, from one of the really true experts of the field. Let's just jump in, all right? So, Dr. Khera, first question. How common is erectile dysfunction in men?
So listen, these patients walk into my office and they come in, they're 50, 60 years old, and they're devastated. They say, I can't believe I have erectile dysfunction. I can't believe this is going to happen to me. And I say to them, Mr. Smith, have you heard the statistics? 40% of men at 40 of men at 40 have erectile dysfunction.
That's high.
50% at 50, 60 at 60, 70 at 70, 100 at 100. The older you get, the more likely you are to get ED, and it's inevitable. So the reality is, Mr. Smith, you're 60 years old, you beat the odds, because 60% of your colleagues currently have erectile dysfunction. So many of these men don't understand that this is supposed to happen as we age, statistically, and that makes them feel better. They understand that. Now the next question is, they say, what are we going to do about it, right?
Yeah, no, I think it's so important that, like, you're not alone, right? That's that's the idea. You know, these guys, they come in and they're uncomfortable because they think that they have this special secret that no one else has.
Yeah.
And I think there is a lot of value in exactly what you said, that, you know, most people are going to have it. And if they don't have it already. So you're right.
It's like the way the patients come out and say it to us. They're like, hey, doc, look, like, you know, it's just not like when I was 20 years old, you know, like, and you're like, well, yeah, dude. Yeah. Like,
Yeah.
that's normal.
True. And there's also this concept of use it or lose it, right? So I tell patients, if you think about the penile muscles, there's two muscles running in parallel. You know, the best example, like you have an arm, there's a bicep here. And if I put your arm in a cast and took that cast off after 6 months, what do you think would happen? It would atrophy, right? And if I took the other arm and I had you lift dumbbells every day, the arm would hypertrophy. And so typically, you know, men, typically around the ages of 50 and 60, will start developing more ED. And the reason being, I think, is because many of their wives or their partners, roughly around 52 years of age, go through menopause and are no longer interested in engaging in sexual activity. So they decrease the amount of sexual activity they have, and therefore they can start getting some more atrophy. Now, look, other conditions kick in like obesity, diabetes, comorbid conditions, but that's kind of the zone 50 to 60 where you start seeing like an uptick in ED.
Gotcha.
All right.
So I think you highlighted really well. Let's just touch on that real quick. What are some easy lifestyle modifications that a guy can do to address potentially developing or, you know, getting ED?
Yeah, I love that question, because when patients come in, they say to me, I want the pill. I say, look, you want the pill, then what's going to happen is I give you the pill like Viagra, and you remember 40% at 40, 50% at 50. What's going to happen is eventually the disease is going to get worse and worse, where Viagra will stop working, right? So Viagra is not a cure. Viagra is a Band-Aid on a problem, and you're watching the disease get worse every year, right? That's what Viagra is, right? So if you really want to get to the core, it's lifestyle modification. And there are 4 things that are critical. It's diet, it's exercise, it's sleep, and it's stress reduction. Those are the cores. Men are stressed, you're going to have more ED. You're fatigued, you're not sleeping, ED rates will go up. And if you're not eating well and you're not exercising, and each one of these, particularly diet and exercise, has been shown to reverse the ED process, right? So typically, if you're going for the cure, you have to help me with lifestyle modification. I'm a little biased. I do like daily Cialis also. And there've been animal studies, even human trials, looking at giving daily Cialis and showing the potential of hypertrophy of the muscle. So over time, it gets stronger. So to me, daily Cialis is a little bit more on the cure side, as opposed to giving you just Viagra whenever you want to have sex.
That's really interesting. And I think those four aspects, obviously the Cialis, we'll get a little bit more into that in a little bit, but those four aspects are so important because people don't think about these things. Like, I feel like health, like in terms of diet and exercise, those are more straightforward and kind of obvious, but the sleep I find interesting.
Critical.
And obviously stress. And that's where, the men under 60, we see a lot of have ED, these 20-year-olds, these 30-year-olds, these 40-year-olds, the anxiety, the lack of sleep. I think that those parts, obviously diet and being overweight, those don't help, but I think those are really, really excellent points you brought up for sure.
Justin, you nailed it, because think about what you just said. So a 20-year-old guy, 25 or about ED, usually doesn't have advanced diabetes, obesity, metabolic syndrome. He usually doesn't have any comorbid conditions. So why does he have ED? It's usually psychogenic, stress probably related, but other causes. But it's not an organic cause,
Right. So now that we touched on the lifestyles modifications that we can do for ED, what are just a first general overview of all non-surgical options for erectile dysfunction?
Right. So we used to call this levels: level 1, level 2, level 3. In the old days, we'd say level 1 are meds. If the meds don't work, go on to penile injections. If the penile injections don't work, go into a penile prosthesis. But in 2018, that changed, and the new AUA guidelines, American Urologic Association guidelines, say, look, when a patient walks in, you should tell them about all the options. They don't have to go in that linear fashion. And if they choose to start with injections, that's fine, because you've told them about all the risks and benefits of each of the options. But at the very beginning, we always start with lifestyle modification, and medications. Pills are the easiest way to go. So we have 4 pills on the market. We have Viagra, Levitra, Stendra, and Cialis. And so we offer them a pill. Now, in that same category, you can also offer them urethral suppositories, although they're not very common anymore and they're more difficult to find. And I would say they're not as effective as the other medications. Then they're in the same category. I also use supplements sometimes. We know that amino acids, potentially, soft call, but could, like arginine, carnitine, citrulline, could be helpful. When you put those 3 amino acids together, that equals nitric oxide. So then those could be very helpful. And then we move on into a vacuum erection device, which is an option. Penile injections, which should be taught in the office initially. And then if those are not effective, we can also use a penile prosthesis. Now, overlying this whole thing are clinical trials, right? So both of you are in academic institutions and you're running clinical trials. So there are trials using shockwave therapy, PRP, stem cells. There are other alternatives besides what I'm telling you that can also be helpful.
That is an excellent summary. And
yeah,
I know Kevin is doing a lot of that work on PRP and shockwave and everything. So Kevin and you, I know, have talked about that at length, and you guys are pretty much very knowledgeable in that. But I think let's just start off with like the general things, and going back to Cialis and Viagra. One thing that I think that we all come across is patients, when we give them Viagra or Cialis or Levitra or Stendra, we always have to make sure that they're taking it right. We see these patients, they come in, They go, "Doc, I took Viagra, it doesn't work at all." And you go, well, the first question is, how'd you take it?
Yeah.
So can you just describe to us the proper way to take, I think it's usually like Viagra or Cialis are the ones that we instruct on proper usage, because I think that's one of the main reasons why it doesn't work for people.
Justin, I couldn't agree with you more. Let's think about how these men want to take the medication. What they want to do is they want to have a great dinner, a couple glasses of wine, a couple of cocktails, come home. They decide they want to have sex, and then they take the pill.
That's the way I play it out. That's the way I play it out.
That's the way you do. You have your dinner, your cocktails, your wine. Then you come home, you want to have sex. You take the pill, and you say it doesn't work, right? And the reality is, and you both know this, is that that's not how you take the medication. Ideally, what you want them to do is take it on an empty stomach before they go out to dinner, right? That's the ideal. Well, they say, "Doc, it's going to wear off in an hour, and I'm not going to have sex in an hour." I say, it's not going to wear off. It'll last 8 to 12 hours. You'll be fine. Take it before you go to dinner, right? And then see how efficacious it is after when you want to engage in sexual activity. So that's really important. The second thing you want to remember, and Andy McCullough did a great study, is that the first time someone is taking this medication, many times they're nervous. They can undergo an adrenergic response, like they tighten up and the blood pressure can go up. And so really he showed his was excessive. He said that you need to show 8 times that it didn't work. I think that's a little high, but at least on 3 different occasions, that you have tried the medication, but you're not going to take it one time. Let's say that patient said, I took it one time on an empty stomach, it didn't work. Doesn't matter. Where are the other 2 times? Give me 3 times to let me know that you took it several times properly and it was not effective. So that, I think, is a very important point when these patients are taking the medication. Some, like Avanafil, says that you can take it with food and alcohol. It says in the package insert. And that's true, but I think it works better when you don't, right? So you can take it with food and alcohol. It does work as early as 15 minutes, but I think all of them work better when you take it on an empty stomach several hours, not even 1 hour, several hours before you engage in sexual activity.
Well, I think the other thing that, the benefit that you talked about of Cialis is how long it lasts in the body too. And that is the only one where you have this option to take it daily. And I think a lot of patients prefer that option because instead of the story that you just told where they're saying, oh, well, I got to take it before dinner, I'm scheduling it. And if you just take 5 milligrams every day, you're kind of, after a couple of days, you're at a baseline level and you're pretty good. And I think a lot of patients who are, unfortunately, they're probably taking other medications, sometimes prefer that method too. So I think it's always important for patients to realize that there are different options and different ways you can also take the medications for your convenience. Maybe you just don't want to deal with the stress of scheduling taking a pill as well.
Yeah, and so I agree. I think that the daily Cialis, like I mentioned earlier, to me is more of a cure. And I think it's extremely important that patients take that daily Cialis. But remember that the dose for actual intercourse is 20 milligrams and the daily is 5. So sometimes the delta, they need that delta. So many of these patients will take 10 or 15 milligrams before sex on top of the daily 5 if they need it. And I think that combination works better than just taking 5 alone or 20 on demand. The 5 plus the 10 or 15 when you need it is very effective.
Nice. And also another observation I made is also, some patients coming in are like, look, my buddy, that Cialis, it works for him and it's not working for me. But you know what? Look, the Viagra may actually work better for you, Like these medications can be used, if one works for one patient, the other one may not work for the other one. So
you nailed it. That's exactly right. If one's not effective, you can always switch it. And the same goes with adverse side effects, right? If one gives you a side effect, the other one may not. We all know Cialis, for example, back pain. Viagra, more visual changes, yes, right? Yeah. So if you're getting a side effect with one, switch it. If you're not getting efficacy with one, switch it, right? You can always change it and you may get more efficacy with one or the other. So I think you're correct is that, everyone needs to find out what works best for them.
That's excellent. Now, are there concerns of, patients always ask, I'm taking these medications, I have these other issues. What medications would prevent someone from taking something like Viagra or Cialis? I guess an oral PDE5 is what we call them.
What we worry about, Justin, is dropping the blood pressure, right? So if I drop the blood pressure, the biggest concern, the largest concern, black box warning, is if you take it with nitrates. So if I'm taking a nitrate because I have chest pain, and I had Viagra on board at the same time, I can drop my blood pressure so much I can die, right? So it can be fatal. So a couple of things you want to remember. One is that if a patient takes Viagra today and goes to the ER tomorrow for chest pain, he can take the nitrate because it's been 24 hours. If he takes Cialis today and has chest pain tomorrow and goes to the ER, they can't.
That's a great point.
That's a great point.
Right? So you got to be really careful on what you gave them and your concern for, cardiovascular events. So that's very important. So nitrates are number one. Now, remember this, nitrates can come in other forms besides chest pain. Do you know what one of the key treatments are for patients who have anal fissures? A key treatment for anal fissures is nitroglycerin suppositories.
Wow.
Nitroglycerin suppositories.
I had no idea.
That's how you treat a lot of anal fissures. So if he says, no, doc, I don't take any nitrates for my heart, but how about, for your anal fissure? I mean, nitrate's a nitrate, right? So just be very careful. You concomitant nitrate, any kind of concomitant nitrate with the PDE5 inhibitor can drop the blood pressure. So that's very, very important. You don't want to be, careful when you mix those two medications. There's other medications that are a warning, and many men take alpha blockers, right? They take alpha blockers to help urinate, Flomax, Eroxetrol. Well, you shouldn't take those medications together. There's some discussion on at least splitting them at least 4 hours apart so that you're not taking them together so you don't drop it. So there's a warning. It's not a contraindication, but a warning that you may drop your blood pressure. And there's also a warning with alcohol as well. Excessive alcohol can drop the blood pressure as well. So again, just the nitrates are number one, but anything else that can drop the blood pressure, just be a little careful when you take these medications.
That's excellent. I think also there's something I wanted to mention, which I didn't think about until someone actually came up to me. It was a patient who was taking something called poppers, which are actually over the counter. You can inhale them, and you buy them like bodegas. It kind of relaxes you. It can also lower your blood pressure. And they are also contraindicated if you're taking Cialis or Viagra. I don't actually know the medical term for them, but I just know that they are called poppers. I don't know if you guys have heard of that.
Yeah.
But
I think you got to be careful. Just you make up a point, because there are many supplements that are on the counter. You can go to any convenience store and pick up a supplement. And the problem with these supplements is that they're not FDA approved, and they are not tested for efficacy and safety. So if you said, where's the study that showed this was safe? Where's the study that shows this is efficacious? Typically, they don't exist. The problem with the supplements that you get over the counter is that many times they contain Viagra in them. Now, why is that important? Because if you're taking nitrates, you wouldn't know that the supplements contraindicate, right? You wouldn't know that, and you could drop your blood pressure. So many of them have PD5 inhibitor in the supplement. And so a word of wisdom is if you're taking any of these supplements and nitrates, don't take them together, or don't take the supplements, right?
I think that's a wonderful point, because, I people come in all the time. They go, yeah, I've been taking this medication I buy at the gas station all the time. And
hear that a lot. Hear that a lot.
You hear it way more than I thought. And, you got to be careful, because you don't know what's in it. And it might work for those reasons, exactly what you said.
Yeah.
So that's a great point.
Quick recap. If you have anal fissures or you got chest pain, think a little bit before but let's pivot a little bit. Let's now talk about something that patients come up to me and they will say, like, I've heard about it, I've seen it on TV, but these vacuum erection devices. So can they really help with erectile dysfunction, and how do they work?
Yeah. So the vacuum erection device is exactly what it sounds like. It's a vacuum. Right? Essentially, it's a cylinder that's placed on the penis. It's a vacuum. It induces an erection. In order to maintain that erection, a band is placed at the base. Now, it's pretty clever. I just want to remind you the anatomy. So think of the penis as two tubes, okay? Two tubes. Down the center of the tube is an artery. On the periphery, right below the casing of the tube, are the veins, right? So it's a clever system. The more blood comes in, as you expand it, you press the walls and you block the flow of the blood coming out. So if a man took his hand and placed his hand at the base of the penis at the 5 or 7 o'clock, it just compressed right there, he would notice that he'd start inducing an erection, because he's blocking the outflow. So the way you do this is you use the vacuum erection device, it induces an erection, and then the band is placed at the base of the penis around the veins to compress them.
Traps the blood.
There's no outflow. So it's a very clever device. It's very effective. And what the biggest benefit of this device is it the only thing that doesn't cost money every time you engage in sexual activity, right? So you buy it.
Good point.
Time you have sex, right? So it's, for cost purposes, it's very good. The other thing that's very beneficial about it is that it's not systemic, right? There's nothing entering there's not a side effect like a runny nose, headache. I mean, they basically, it's external, and it's not a systemic drug into the bloodstream. So that can be very helpful for many cases. So I do think it's beneficial. I think some of the drawbacks with the vacuum erection device is that it's time consuming. Many patients say that it ruins the spontaneity. They say the rigidity may not be as well as other forms of medications. So there are some drawbacks, but I have some patients that love it and they just swear by it and they just keep using the vacuum.
It's awesome. And I think a lot of people actually also use it to help them with when they're taking Viagra or Cialis, or they're taking other things too. It's kind of like a synergistic effect in many ways. To kind of help. So I have a lot of patients like it.
There's several other ways to use the vacuum that we see not conventional. So conventional is ED. But let's talk about some non-conventional ways. So a vacuum is commonly used in men recovering from radical prostatectomy, right? So some of these men have a loss of penile length. And the vacuum and several studies have shown that not only can you maintain that penile length, but you may even gain some penile length by using the vacuum after a radical prostatectomy. So that's important to a lot of men. Off-label, again, the vacuum is also used in men for Peyronie's disease. So men who have Peyronie's, as you both know, are an abnormal curvature of the penis when it's erect. And when you use the vacuum, it can help with hourglass deformity in some cases, but it also can help with curvature and length of the penile tissue. And many of us will also use the vacuum erection device for patients prior to undergoing a penile prosthesis surgery. So typically my patients will get the vacuum 7 weeks before surgery. That 7 weeks is based on a study by Marty Deneen, showing that they use a vacuum for 7 weeks. By the time of surgery, you can use a larger penile prosthesis. And so many men are very motivated to use it. So it's not just about ED. There are many other ways that we use this vacuum in clinical practice.
It's an excellent device.
Yeah.
And it works. It can work.
Yeah. All right. So let's move on. So say someone either is not interested in pills or pills aren't working anymore. They're not interested in a vacuum erection device. What about, and then they come in, they say, I heard about these injections. How do they work? Like who's doing the injection? And what are the risks,
Yeah. So first you want to ask, why is the pill not working anymore? Why?
Right.
It was working before, it's not working now. And so one of the things we also want to be cognizant of is their testosterone level. Because if you remember that PD5 inhibitors, Viagra-like medications, are not as effective if the testosterone level is low.
Correct.
And if you replace the testosterone, 30 to 50% of patients can become responders to PD5 inhibitors once again. So maybe his testosterone has gone down. Maybe we want to check it and look and see if that's the reason for the efficacy. You also want to check and make sure that they are taking the medication properly as well. And then those psychogenic causes as well. Stress, new partner, a lot lost their job. We see a lot in the pandemic. A lot of that's been going on. So that's important. But let's say you rule all those out. So the next option, or one of the next options, is penile injections. And they work great. They've been around for over 3 decades. These medications are basically injected into the corpora cavernosa, the penile bodies, and they induce an erection. And one of the benefits about this medication is that it's very affordable. They can come commercially, like Edex, which is a little more pricey, or you can get it from a compounding pharmacy, which is very cheap. It's about $3 an injection. The key is that you have to really give the first injection in the office.
Yes.
Because if patients get a priapism, which is a prolonged erection for more than 4 hours, they will need to go to the ER to get medical attention. And what you don't want to do is set that up. You want to show them how to prevent priapism, and you want to make sure they don't get that in the ER, in the clinic. So teaching them is very important. You want to let them know that there is a risk for increased scarring into the corpora cavernosa. Some patients have a slightly increased risk for Peyronie's disease as well. And so they'll say, I didn't know that. You say, no, we talked about there's a slight increase of Peyronie's disease, increased risk for bleeding and bruising, right? So let's be real. So bleeding, bruising, scarring can occur as well. But let's be real. This is not a cure for ED. Right. This is just a Band-Aid while ED gets worse and the patient may go on to a penile prosthesis, right? That's what you're providing them. And I want them to make sure they understand that. And so when we tell them, if you use these injections, don't be surprised if your dose keeps going up. It keeps going up until it's no longer effective anymore. It's really important to counsel them on that.
Now, are the injections painful? Because that's the first thing that patients, when I talk about it, I go, you're going to love the effects. It's going to work for you. Hopefully, like you said, it's a Band-Aid and it's almost like a ticking time bomb at some point, but usually you get some success. Now, the first question is it going to hurt? How do you talk to your patients? What should you tell them?
Two ways to think about pain. One is the pain of the needle going in, the injection. And the second is a burning sensation that some men may feel. Now, that burning sensation is not common, but it's a little more common in men who've had a history of a radical prostatectomy, particularly because of the nerve. So the prostaglandin is one part of the trimix. That prostaglandin can cause some burning. And so one quick thing to do, it's called trimix because it has 3 medications. If a man says he has burning, you just take out one of the medications and you give him bimix. So that burning will go away if you take out the prostaglandin. The second kind of pain that you're describing is actually the needle going into the penile bodies. What's nice about trimix is that it's not viscous. It's very liquid. And so the needle can typically be a 27 gauge. Some have even used a 29 gauge, but it's a very small needle that you need. So many men, when they do the demo in the office, say that wasn't that bad because it's a small needle. I would only argue that as men develop more scarring and they use it more often, many times they're going to be required to use a larger and larger needle in order to get in. And the 29 is going to bend, then the 27 is going to bend, you get to 25.
Yeah.
They have to go up on the needle, and that may cause more discomfort.
That's a good point. You kind of alluded to it, like one of the big side effects is what we call priapism, and that's something that you see on TV when they talk about a lot of these medications, and you see it in movies, you see it in TV shows, and I think it's kind of important to mention, like, you didn't mention that as a side effect for Viagra or Cialis, despite in the movies and the TV shows, that's something that they always show. So this is a problem really for the injections, right? Is this something that if you do take Viagra or Cialis, that can happen?
There is a mentioned and a theoretical risk of getting a priapism with a Viagra, Levitra, Cialis medication. It's in the package insert, and it is a possibility. I have not seen that in clinical practice in 21 years, but it is a possibility, and patients should be aware that it could happen. Right. And if they have a prolonged erection greater than 4 hours after taking Viagra, Levitra, Cialis, they should seek medical care, right? What exactly is priapism? Priapism essentially means that there's no blood going in and out of the penile tissue.
Right.
It's becoming ischemic. And I tell patients the best example I can give you is if I take a rubber band and wrap it numerous times around your finger, what's going to happen? No blood will go in and out. And guess what's going to happen? It's going to start to hurt.
It's going to hurt real bad.
Yeah, really bad.
Right. And guess what's going to happen? We know that after 6 hours, you're going to get irreversible damage to this muscle. It's going to become ischemic and damaged. The same principles. So we have to get that blood flowing again. And so that's what priapism is. So why do we seek attention at 4 hours? Because at 6 hours, you start seeing irreversible damage.
Bad news.
And that damage can be a
very
problem.
Bad news.
At 36 hours, statistically, at 36 hours, the man will not regain his erectile function. And the AUA guidelines that just came out say that you can even put a penile prosthesis in at 36 hours because the likelihood is very, very low you will get a recovery of erectile function. So remember, at 4 hours, you seek medical attention. At 6 hours is where you start getting irreversible damage. And you really want to get that blood flow to start cycling again.
So, I mean, I think, Dr. Khera, us talking about priapisms, it really goes back to highlight one of the things that you mentioned earlier, that the first injections that you get should really be done in an office with a urologist. I mean, I think all of us see a lot of patients who, there's a lot of these online men's health clinics that will literally give you the medications and just kind of give you instructions and for you to do it on your own. And we see a lot of these patients, unfortunately, later in the emergency room with the priapism. So I think, one of the things I want to highlight here is that it's really important to go through the process. There's us, there's Dr. Khera, we're here to be available and to have proper teaching in a lot of these medications, and you can avoid some of these things, hopefully, if done correctly.
Excellent.
Absolutely right. Because Justin, I'm sorry, go ahead.
No, I was just agreeing. Go ahead.
So I agree. And Kevin, I think the key thing is it has to be someone who's trained and who can manage the complications.
Right.
So if you're going to give someone something or give them a treatment, you should be able to also say, I can manage the complications.
Yes.
And the frustrating part with the urologist is that someone else will give the medication, will not train on the medication, hand the medication, the priapism will occur, and at 2 a.m, I get the call to say, someone else gave him the medication, but can you wake up and come deal with it? And you can take it to some degree, but if it happens over and over again, you say, wait a minute, this is wrong not only for me, but it's wrong for the patient. Why should the patient have to deal with this? The proper teaching, instructing them how to titrate up. We have a whole protocol, I know you guys do too, on how to titrate up slowly. I tell patients you want to get 80% rigidity because you'll get the other with foreplay. You don't need 100% just with the injection, right? So there are things you can do to make sure that we don't get the priapism. But I think you nailed it. You absolutely want to make sure, and this is in the AUA guidelines. First teaching should be done in the office with instructing them how to properly do it, because sometimes patients will inject in the urethra. They don't know the anatomy. So, they need to be properly taught on how to do it and how to prevent the complication. And if you're going to give them this medication, you should be able to manage the complications.
Excellent point. Excellent point. I know we're running out of time. I did want to quickly mention the last option, which is the penile implant. I think that is obviously the last line for patients, and it's more invasive, right? It's an actual surgery. If you could just give us like a 30-second quick, I know the implant we could talk for 10 days on, but if you could just talk quickly about it.
Absolutely. Look, the penile implant was invented in 1972. So next year will be, or 1973. So in 2 years, it will be 50 years since the implant was invented.
Wow.
Here at Baylor College of Medicine.
Dr. Scott.
Dr. Scott. It's a phenomenal device. And if everything I mentioned today, it has the highest satisfaction. If you give satisfaction scores of any of these treatments, patients always give the highest satisfaction. And the most common thing you'll say is, I wish I had done this before, right? But it's the phobia of having a surgery that kind of holds them back. But the reality is it's a procedure that it can be done in less than an hour. Patients are able to have an implant that's concealed in the body. You're not able to see it. You reach down into the scrotum, you press a pump, and it brings water, we call normal saline, out of a small reservoir into the penile bodies and induces an erection. The patient can maintain that erection as long as they want, and then when they're finishing with intercourse, they can release it, and the penis will then become flaccid again. So it's a phenomenal device, and again, the patient satisfaction is very high.
That's amazing.
It's a great summary.
I think that was an incredible summary. And I think that, we obviously all treat patients, and you're right. Patients are so happy, and they come in and they go, the only regret is I didn't do it sooner. And you're absolutely right. And then I just wanted to just comment, because everything that you've said is, you gave such a great review. And when we go back to looking at the preventative measures, all of the things that we talk about, obviously today, are many of them, like you said, are Band-Aids, other than diet, exercise, good sleep, and, reducing your anxiety. And I think another aspect of that is obviously the mental health aspect. We do refer a lot to sex therapists, and that's something that we should, there should be less of a stigma on, because even if you're having these issues, talking to someone else is always a great option. And it's always, we were just talking all together just before we came on about one of Dr. Lisa Paz, who was on the podcast with us before, how she's a great resource for, I know Kevin and I, and Dr. Khera has met her as well. So, that's an important thing as well, that patients shouldn't be afraid to go see and talk with.
You're absolutely correct. And I can't tell you how important that is. The sex therapists have a huge role in treating sexual medicine. The issue is a lot of men just say, I just want the pill, right? And they're not going for the cure. They're going for the Band-Aid. And when you start going for the cure with the diet, exercise, sleep, stress reduction, and sex therapy, that is a much better outcome than going for the Band-Aid, right? And what's been really nice in the pandemic is that a lot of the sex therapists are now doing virtual therapy. Because a lot of men just don't want to go into the office and see the therapist and go after work. They're just here in their office talking to the sex therapist. And that's helped us a lot. A lot of them are getting virtual visits with the sex therapist.
Awesome.
That's great. And I think this can be a little bit of a cliffhanger leading in. What definitely want to have you back, Dr. Khera, because we've talked about, treating it, the Band-Aids, but, restorative therapies is something we can talk about next. And, where you should actually go get restorative therapies and all that stuff. But we can leave that for the next podcast.
And you guys are like the masters of talking about that. So we'll definitely have to have another episode. But until then, I do want to thank you so much, Dr. Khera.
Thank you so much,
awesome.
Dr. Khera. This is great.
I know I learned a lot. I'm sure Kevin learned a lot. It's always great talking with you, a true master in the field of urology and andrology. And we're definitely looking forward to having you back on. To our listeners, thanks as always for listening. Dr. Khera, tell everyone where they can follow you or find you.
Yeah, I'm in Houston at Baylor College of Medicine. I'm on Twitter at drmohitkhera.com, website drmohitkhera.com, and happy to take any questions or comments. You can go to the website and put any questions you want in there.
Awesome.
Great. He's an amazing resource for patients and also other urologists. Like always, you can listen to us on any podcasting platform, iTunes, Spotify. Download, subscribe, give us a review, 5 stars, and a comment. Always appreciated. You can follow us on TikTok, Instagram, Twitter, and any questions, comments, concerns, feel free to reach out to Kevin or I through our social media as well. For Kevin and Dr. Khera, thanks for listening. Have a good one, guys, and have a good day.
Thank you.
Thanks.